It happened to me today that I got a patient who is a 50-year-old female who met me with a symptom of pain in the wrist and the fingers as well as morning stiffness. This lady was having this early morning stiffness in her wrist and fingers for the past a month or so. She thought that because of the cold weather the fingers are getting stiff, but as days passed by the stiffness tend to get deteriorated, and then she met a rheumatologist because someone told that rheumatologists are the right people to consult it for. So fortunately she met a rheumatologist, and then that rheumatologist subjected her to a battery of tests, and then she diagnosed her as having a seronegative arthritis. Now I want to tell you what is seronegative arthritis. Arthritis broadly can be classified into inflammatory and non-inflammatory arthritis. Your RA, ankylosing spondylitis, psoriatic arthritis, rheumatoid arthritis, they all come under inflammatory arthritis. Your osteoarthritis, what we commonly see in our clinical practice, osteoarthritis of the knee joint, osteoarthritis of the hip joint, they are all coming under non-inflammatory arthritis. Under inflammatory arthritis, you can further subdivide into seronegative and seropositive arthritis. In seropositive arthritis, the RF factor and the anti-CCP will be positive, for that to be classified as seropositive arthritis. In seropositive arthritis, it's pretty clear that the patient's blood will have a RA factor positive, anti-CCP positive, and of course their ESR and CRP will be elevated from moderate to severe level. In contrast to that, in seronegative arthritis, the blood will not reveal that they have arthritis, but still they will be having the inflammatory arthritis in their joints. In seronegative arthritis, since the blood report will not show that they have arthritis, typically they will be having negative RA factor, negative anti-CCP, even ESR and CRP can be mildly elevated or moderately elevated, but even in common cold you may get ESR elevated, even in an acute infection you may get ESR elevated. So ESR elevated itself will not prove that the patient is having an inflammatory arthritis or a seronegative arthritis. So the intent of my talk today is to make you understand how to clinically discern a seronegative arthritis from the other form of arthritis. In seronegative arthritis, though the blood value does not show the RA factor positive and anti-CCP positive, clinically you can diagnose. How? This arthritis will be having early morning stiffness. You need to ask your patient, do you have morning stiffness when you wake up, and as day progresses the stiffness they tend to get better. Do you think your movements is making your stiffness better? Do you get the pain symmetrical in nature? What is symmetrical? Both right and left will be equally involved. It is one of the hallmark sign of inflammatory arthritis, because the inflammation in the blood will not consider the side, so they will get both right and left side. So typically it is symmetrical, but at the same time don't get deceived by the word typical. I have seen some patients who had asymmetrical type of arthritis, but they fell under the category of inflammatory arthritis. For example, I saw one girl who was having a botanist type of deformity. That's all she was having, and she was having pain over the same IP joint of the finger. Upon further investigation, we found that she was having strong rheumatological factor positive with strong elevation of ESR and CRP, and then we subjected her for the medications. So this is one example of how the inflammatory arthritis can be sometimes misleading, but generally it has a pattern. Most of the times you can actually pick it up. How? The early morning stiffness, and then symmetrical in nature, the presentations are movements tend to get improve their pain, or as the temperature increases in the middle of the day, the pain tend to get improved, or the stiffness tend to get improved. It's mainly the stiffness followed by the pain. Apart from that, you may also notice some sort of swelling which will be happening in the wrist or in the finger level. Typically what I do is, say in the inflammatory arthritis, if I suspect someone who is having rheumatoid arthritis of their fingers, I do this simple test, extension of the MCP joint and flexion of the MCP joint in order to make a knuckle breaking sound. If I am able to break the knuckles, then I know that the joint has moved to the end range and the joint cavity is intact. Remember that for the knuckle sound to break, the joint cavity which is covered by the synovium must be intact. But in rheumatoid arthritis or in other inflammatory type of arthritis, it mainly affects the synovium, which is a form of connective tissues. You know what, all these inflammatory arthritis, they affect the connective tissues first. So the synovium will be affected, so it cannot contain a cavity within the joint. Because there is no cavity within the joint, there can't be any air within that, and hence whenever you try to break the knuckle sound, they will not be able to produce a sound. That indicates that the synovium is already punctured, it is not working normally, so the joint cavity is not maintained. In that way, we can pick up the early rheumatoid arthritis, alright, but sometimes it may not affect the finger, it can affect the elbow. So in that case, this test will be proving wrong. These inflammatory arthritis can affect the other joints as well. Sometimes it can be a monoarthritis where only one joint will be affected. Sometimes it will be oligoarthritis, and sometimes it will be polyarthritis where 3 or more joints will be involved. In this patient who I have been seeing, this lady was also having a shoulder pain. Okay, when I checked the range was limited at the end range. When I was checking the passive range was limited up to 170 degree, and it was having similar restriction in the other side also. So remember, bilateral symmetrical restriction, and this patient, she was experiencing a mild shoulder pain, but she didn't even brought this shoulder pain to the notice of her rheumatologist, thinking that was irrelevant. Okay, but you know what, this is also a part of rheumatoid arthritis. Whenever there's a mild pain, people tend to ignore, but as this joint gets deteriorated, the range restriction will be keep on increasing. Now what I see as 170 degree is the maximum range. After 6 months, if we don't intervene, it will become 160 degree, and after 1 or 2 years if we see, it will become like 140 degree. Gradually, year by year, as the disease progresses, the joint range will be gradually reduced, and at some point it becomes a deformed joint. That's why when you are seeing a patient with rheumatoid arthritis, as a physiotherapist, you have to check every joint and check whether the joint is going till the end range. If it is not going till the end range, you have to do the movement as an exercise so that they maintain the end range as much as possible. If not, they will be slowly losing the range. Even though my patient was concerned about the finger and the wrist pain, the disease has affected the shoulder joint as well silently. My patient is currently under a rheumatologist care, which is very important for this disease, because in rheumatoid arthritis, medical management is the first line of treatment, and physiotherapy management is equally important, that should go along well with the medical management. The drugs what the patients are taking for the disease is only a disease modifying drug. It cannot cure the disease, but it can control the disease from progressing further. But whatever joint which was damaged by the disease, the joint range will be established only by physiotherapy. The drugs what you are consuming for the disease will not restore the last range. The last range can be restored only by physiotherapy. Make sure that you diagnose your condition first. If in case if it is in rheumatoid arthritis, meet a rheumatologist. Don't go for any other alternative form of treatment. To my understanding, there is no alternative treatment for inflammatory arthritis or autoimmune type of arthritis in other forms of treatment except modern medical science, which is practiced by the medical doctors. Okay, they will give you the right drug in order to reduce the inflammation. At the same time, every inflammatory arthritis patient or RA patients must visit the physiotherapist to make sure that their joint ranges are maintained, their muscle power is intact, they are not leading towards a deformity, so that the patient's musculoskeletal health will be maintained. So this condition, you have to deal with it for the entire life. Once it is identified as an RA, lifelong you are having RA, you cannot actually cure RA by any other alternative form of treatment. At least there is a hope in modern medical science where a rheumatologist and a physiotherapist can make an ideal combination in order to help the patients to deal with this disease, so that the musculoskeletal health, the pain, the overall mobility, strength and endurance are taken care by the physiotherapist. If you are a RA patient, even though you are taking medicines correctly, even though you are doing well, make sure that at least 6 months once you meet a physiotherapist to just get your joints checked, because you will never know, silently some joint will be slowly losing its range. Okay, you will not know until 20 to 30% range is lost, because most of our functional movements are done within 20 to 30% of the ranges itself. You will not know the extremes of the range which is lost until it's lost more than 50%. So these physiotherapists will help you in identifying the movement loss and make sure that you get the end range at all point of time in your entire lifetime. This is the only way to prevent the deformities, because sometimes when we see a rheumatoid arthritis patient coming to us in the terminal stage, we only can think, if this patient had come to us 15 to 20 years back, we could have avoided the deformity, we could have avoided the surgery, we could have prevented the lifelong disability. So early identification and early intervention is the key here. Don't waste your time. Do the regular blood work, meet your rheumatologist regularly and the physiotherapist to make sure that your joint health and the overall musculoskeletal health is maintained. Coming back to my patient, so this patient is doing very well now, even though her blood work shows that the RA and anti-CCP was negative, her ESR and CRP was slightly elevated, but clinically she was having bilateral joint distribution and she is having swelling in both the wrist and then early morning stiffness. Additionally, her first MCP joint of the thumb of right as well as left were equally restricted. So these are all the clinical signs that we used to confirm that she is having inflammatory arthritis, which fall under the category of polyarthritis, because more than 3 joints are involved here, both the sides thumb, both the sides shoulder. See, this is a form of polyarthritis. Though biochemically we could not diagnose, but clinically we could diagnose her as having seronegative arthritis. In that way, we saved the patient from getting the permanent deformity of the shoulder and the wrist, because we have already started moving the thumb. She is already feeling better in terms of range. The shoulder joint range is almost, we got it fully. So now she'll be doing the exercise in the home to maintain the range and meet us once in a month. We also can establish whether the medicine is working well or not by the clinical symptoms. So in that way, we are currently managing this patient very well, and I only want every RA patient in this country take control of the disease in the very early stage. You can lead a very normal life. In seronegative arthritis, the RA factor and anti-CCP shall be negative, but clinically if they have symmetrical joint involvement, early morning stiffness, restricted passive range of motion in one of the joints in the hands, and if the condition is worsening with the cold weathers, with or without swelling, then these are the clinical clusters that you can use to confirm it as seronegative arthritis. Now, if you are a physio and if the patient directly come to you with the same symptom, then you should be able to at least sense that, yeah, it could be an inflammatory arthritis. In that case, you should not treat the patient first. You need to refer them to the rheumatologist. The rheumatologist will subject the patient with some blood test to confirm certain things, and then they give the medicine if it is a seronegative arthritis. Once the medical management was started, then the patient should come back to the physio, then start do the physiotherapy part. Okay, in that way, the medical management and the physiotherapy management should go well together. Alright, this is how you have to do as a physiotherapist. When someone has already got the diagnosis done and taking the medicines, then you can just do your job of maintaining the musculoskeletal health. Okay, I hope you learned something about inflammatory arthritis and seronegative arthritis. I'll keep doing video on inflammatory arthritis in the future as well. Alright, thank you.